Our next speaker is Dr. Jeffrey Rice, who is going to discuss why the free market boom. Dr. Rice is the CEO for the healthcare BlueBook, which provides fair pricing to consumers, employers, and providers. He has more than 20 years' experience in clinical information technology and executive management within academic institution, national health plans, and more. We have Dr. Rice slotted from 1 o'clock to 1:45 with some time at the tail end of that built in for questions, and there are microphones in the back. But Dr. Rice has said he doesn't mind or prefers just along the way to make it more interactive, and just if you have a question along the way, maybe stick up your hand and he'll acknowledge you, and then we'll see when we get to 1:45, we'll wrap it up. So please help me welcome Dr. Jeffrey Rice.
Great. Good afternoon. Hopefully not everyone ate the $1.75 chicken fry. Otherwise, you'll probably all be asleep in a minute. I retitled the talk a little bit. I think boom might be a little optimistic for the free market boom. So I think we need a free market. I think we're at the beginning stages. I'm not sure we can say we're in the boom days yet. Would you agree? Yeah. So we want to get there. Let's see if this works. Great. So once again, my name is Jeff Rice. I'm CEO for Healthcare BlueBook. I like to start, with the context of healthcare in the U.S. And the fact is, we spend about $3 trillion a year on healthcare, which is about 20% of every dollar spent in this country. It's quite amazing. And maybe that's a problem. Maybe it's not. It certainly hurts us globally. But the important thing, if you look over on the far right, is I don't know if this pointer works. United States is way out here. We spend 3 to 5 times more than most other countries. But yet, if you look at the quality, whether it's life expectancy or morbidity or whatever the quality metric is, we're not above everyone else. We're not bad. We're pretty good, but we're not above anyone else. We're certainly like 3 to 5 times above. So that's really the challenge for us: is how do we get value out of this system? We have a lot of providers; they provide good care, but they charge. The prices are too high. So that is one of the biggest drivers of this whole thing is the pricing in healthcare. We haven't had a free market. Nobody's paying attention to the bills. We have very, very high pricing. And that sounds great in the abstract, but what does that mean to the patient, right? I'm a physician. It doesn't do any good as a physician to prescribe treatment your patient can't afford. And I've seen patients say, I'm not going to get my foot x-rayed because it's $700. Well, it's not $700. It should be like $50 if you know where to go. So we always look at it from the patient perspective. I'll share a story that happened to me. Jay talked about, sort of personal journey. I'd been working on this for a while and thinking about it, but my son, 3 years ago, I guess it was 4 years ago this fall, he was 12 years old, he has mild CP, and he needed a foot surgery, 1 hour outpatient surgery on his foot. Not that complicated, not a big deal. But he likes to play sports. We're going to go to a really good surgeon. We're travel from Tennessee, where I live, to St. Louis to a really good surgeon. And then I start the scheduling process, right? Healthcare BlueBook, so I call and ask how much it's going to cost. What do you think the facility said? Yeah. They were a little twist. They said, we don't know. Why are you asking? Right. So that's not a great start. So I said, well, you want to get paid. I'm on high deductible plan. I'm going to be writing a check, so I'd like to know what it costs. So they researched it and called me back. $37,000 is the bill charges for 1 hour outpatient surgery. But the good news with your PPO discount, we can get that down to $15,000 to $25,000. Isn't that great? So, thanks. Called the surgeon back and said, do we have some options here? That seems really high for a 1 hour outpatient surgery. He said, yeah, there's another facility. I asked him how good it is. I'm not going to tell my wife we're getting discount surgery, right? So he said, yeah, there's another facility. It's definitely just as good, and it's more convenient. This sounds pretty promising. So this is same surgeon, same town, 3 blocks apart, same insurance network discount. One of them's $15,000 to $25,000. Second facility, $1,500. So, and the point isn't that happened to me. The point is every single day that's what patients face. They have no idea. So, my job, our company's job, is to make sure every patient knows what things should cost and where they can get a good value. And that's what we try to do, and we try to make it really simple, and I'll talk about that simplicity. So let's talk about the free market movement. There are there are different players, and I think there are trends headed in the right direction. Hospital pricing strategies are going to work to the benefit of those that want to provide value. Health plans, and by health plans I mean the insurance companies, not the independent payers, but the people on the insurance side, don't care about costs. I'll talk about that. Independent providers, like those in the room, they want volume. They want to give a good value. Employers don't want to pay more. They're tired of that, and patients don't either. So let's look at those. Hospitals, what do typical hospitals do? I don't know if we have hospitals in the room, I apologize. I might not be too kind to the hospital industry. Everyone else is probably safe. So, consolidate market position, acquire independent imaging centers and surgery centers as fast as you can, buy the physician practices or get right guide rails on those guys, and then go back and negotiate higher rates. This is not helpful to their cause. 2/3, if you look at different data over the last few decades, about 2/3 of the increase in price overall. There are volume issues, there are new technology and stuff, but overall, just pure price increase because they can. And if you look around in different markets, you'll be hard-pressed to find a hospital that has the word value or affordability in their mission statement. There are some states, probably many states, where that's true. It's just a foreign concept to them. So that's a problem, and it's good news for those that want to provide good value because the people you're competing against are not going to compete with you. So what does this look like? This is the sister of one of the executives at our organization, 1963, going back a ways. This is what happens if you cut your finger and went to the ER. Total price, $13.50, and you notice right here, paid in full, the patient paid in full. Okay, not claims submitted, waiting for review. It's patient paid in full. And if you fast forward to more recent times, that bill today, if you adjust it for inflation, is $100. And why would you ever insure anything that's $100? You don't need insurance to pay for that. Well, it's not $100 anymore. It's $2 or $3 grand. And you've seen headlines and horror stories. Sometimes they're a lot higher than that. So that's a challenge for those paying the bill. There we go. What about health plans, insurance companies? Do we think insurance companies are managing cost or risk? Anybody think they're all over that? Okay, no hands. And think about where they live today post-reform. If they don't spend enough on medical cost, the money goes back in a rebate to the clients at the end of the year. If they spend too much, they get a heavy subsidy from the government to cover the loss. The plain fact is, just simple math, they get a percentage of the pie. They're not trying to shrink the pie. It's just a fact. Independent providers are fed up. We heard Jay's introduction, which was awesome. There's got to be a better way. And there are lots of providers out there that want to do a better job, both physicians, facilities, and their real question is, we're here, and why isn't everybody lining up? So we got to try to help them. Employers, last decade or so, seeing almost a doubling in what they're spending. It's not sustainable. That it doesn't work for them. And employees, the patients. Just 4 graphs. The very bottom number is inflation. The next one above that is what their wages have done. So wages are barely keeping up with inflation. If you segmented that out to the bottom half of the income curve, it would be below inflation. So overall, they're not keeping up with inflation, and all the money going to healthcare, 20% of our economy, that's one of the reasons. The top line is insurance, the next line up is insurance premiums increasing, and then how much of that's being shifted to the patient. So that's great news for the free market, because when the patient has skin in the game, they're going to show up. So, apologize for this fast thing. So what does the landscape look like? Once again, health plans, insurance companies, and large provider systems. The deck is stacked, or the field is tilted, if you will, against employers who are paying the bill, patients who are increasingly paying their own way. Average deductibles getting close to $2,000. The average patient doesn't spend $2,000 a year on health care. Therefore, they're all self-pay. And high-value providers. So how can we bring free market and transparency together? You know, the ultimate goal, level the playing field and make it available for the providers and the patients to connect, as Jay said, those that are paying the bill. So I won't say a lot about Healthcare BlueBook, but just to give you some context, I started working on transparency in 2005. We went out in 2007 to try to help patients understand healthcare pricing. The good news for the free market is this is a very hot topic, and many employers are buying into this, if you will, and they want their employees to know what the costs are, what the cost should be, where they can go get a deal. And so we have working with Jay and his team to help promote for his employer groups to get to the Oklahoma Surgery Center and others and make that really easy for them. And lots of big employers, whether it's General Dynamics or the Southern Company or Nissan or Kimberly-Clark or the Hartford. I mean, all these are people that we work with today, like HealthSmart's here. The whole state of West Virginia, for their 90,000 employees and retirees, are doing this starting next month. So there are really big employers that are saying enough's enough. We have to get our employees to understand this stuff. So how do we do that? And you guys feel free to ask questions as we go, as Brandon said. So this is what price variability looks like. This is just a generic graph. Think of each one of those bars as a patient. And the price range, in my son's case, it was $1,500 to $15,000. This example, less than $1,000 to over $6,000. And we like to just make things simple. We break it into green, yellow, and red. Either you have a great price, an okay price, or you're not doing very well by your customer. So, and we set that fair price. And we do it on a national basis. Those kind of price curves, these are more specific ones, whether it's cardiac catheterization, endoscopy, imaging, inpatient care, baby deliveries, it really doesn't matter. Every single market in the U.S., every single network, that's what the pricing curves look like. It's just, it's the way the industry works. So you don't have to go to India or Costa Rica to get your care. You can just typically drive across this, down the street, across town, and get reasonable value, if not really good value. But there's some subtleties to this because patients don't know the health system. I knew how to make phone calls. I'm a physician. I used to run health plans. I sort of know how it works. The average patient, they have no idea, right? So that's all of our jobs, is to make it easy. First thing you'll notice, this is a colonoscopy pricing graph. All these patients are in the same network. They're in the same town. And the price range in this one's $1,000 to $3,500. Notice there's a green part and a blue part to that price. That's the physician fee and the facility. Really important to note, in the vast majority of cases, the physician fees don't vary a lot, and they're not the big piece of the pie. And that has a lot of practical implications that I'll come back to. What we're really talking about is, what facility does your physician practice at? Where do they do your care? I want to say a quick word about quality. Quality also varies. It's one of the newest initiatives we've had. We start on pricing because that's easy, it's a number. For those of you that have tried to document provider quality and outcomes, it's a lot harder. But if you look at trusted data and you do good analytics, you will see variation. And so how do you make that simple and transparent to patients? And we're working on that. The good news, all of the research supports the fact that high prices don't mean high quality. So as a patient, they assume that. It's a faulty assumption. We have to help them around that or over that. But for those that are independent providers, it's a great opportunity to say you can get really good quality care, maybe the best quality care, and still get a good price. I think so that's a challenge. That's an opportunity. The challenge for a lot of independent facilities is most national quality data is based on CMS data. And if you're an independent facility and you're not an inpatient facility, you may not have that data to compare. So, my entreaty to you is start documenting your quality really well, make it defensible, make it sound methodology, and be able to benchmark yourself against the other guys. Because, as clinicians, we'd much prefer to go to independent center, get in and out, and know that we have good nurses and good, high-quality care, and we're not in an inpatient setting having routine stuff done. But for the average consumer, if they're looking at quality data and the quality data is missing on the independent provider, that's going to be a challenge. So we're hoping that the industry will find some fixes to that gap, if you will. Turning back to the patients, how do we get them into the market? Free market, the patients, that's the tip, if you will. We have to get them in there. We have to focus on practical things. I'll talk about that. We have to make it really simple. We need to communicate with them because they don't know, and even provide incentives for them. And then as much as possible, integrate into clinical practice and health system workflow. So whether that's putting it right into the claims flow, putting the tools and technology in the hands of on-site clinicians or primary care doctors so they can make good referrals, all of those things are on the table. We have some experience with most, if not all of them, or many of them, and we have some really good results when you get clinicians thinking this way. So more people like Dr. Smith saying, there's a better way, let us just get you over here and take care of you the right way the first time. Doing things that are practical. Most patients, when they think about their care, they think, well, what doctor am I going to go to, right? Huge problem, huge problem. Those graphs I showed with the pricing variation, if you just pick your doctor 2/3 of the time, you're going to end up at a very expensive facility, and unnecessarily so. So we like to flip that around. What do you need? The procedure, what should it cost? What's the price supposed to be? What building could you have that done at? Which physicians practice there? Because what we know is physicians frequently have a choice. Not always. If they're owned by a hospital system, that may be a little problematic for them. But you don't have to change doctors to get good value. Go to your doctor and sit with them and say, what about the financial side effects of what you're getting ready to do? Where could I go to get a good value? We put all this on a mobile app, if you will, so you can actually talk to your doctor on the spot about that, or the scheduling staff in the doctor's office. But that's a subtlety, but it's very important, because patients want to go pick a doctor, and if they think they shop by picking their doctor, and this doctor was $95 and the other one was $105, and I just save $15 on my doctor, yeah, but when they send you for your MRI and you pay an extra $3,000, you didn't do yourself any favors. The next thing is simplicity. I obviously won't read the quote, but I encourage you guys to do it. And the fact of the matter is, and Job said it well, and others have said it similarly, and that is, it's harder to make things simple. It's really easy to throw more information at people. With the internet, you can fill screens and screens and screens up with data and information, and I can assure you patients don't get it, and they never will. They'll get frustrated, then they'll ask their neighbor or something, they move on. So just to sort of retrace some of the history of where things evolved, everybody remembers Yahoo. It's where we all used to go to search the web. If you go there today, you'll probably do, like if you're like me, you do 5 or 10 things you forget what you went to search about. What do we use today? Let's make it easy. Everybody remember the BlackBerry? Anybody still have one? A couple? So where's the market moved? Get rid of all those keys. One button. So think simplicity, make this easy. Most patients aren't healthcare experts. This is your standard health plan tool. Isn't that inviting? Starts with the doctor, of course, a lot of missing data. Here's another example. And this one, if you read the fine print at the top, the least expensive provider, that's not actually their price, it says here. It says no data available based on market average. That's really helpful. But the scary thing for the independent providers is if you go online and look in the health plan tools, you're probably not even in there. The hospitals are in there. You can shop around for hospitals. Yeah?
Another interesting thing is they don't quote the price. They quote the
out-of-pocket costs. Yeah, great point on this particular one. It's what your out-of-pocket costs are, not the real cost. Yeah, and that's true for the vast majority of insurance company tools. So we try to reframe this and think about it a little differently. And this is just what sort of a BlueBook transparency solution would look like. What do I need? Make it easy to search. And it's not about doctors searching, it's about MRIs, colonoscopies, surgeries, et cetera. There we go. What should it cost? So this is sort of important. In network for this particular zip code, the price range for this procedure, $1,200 to $9,800. Most patients have no idea. We've trained them in managed care industry, trained patients for the last 2 decades. Go in network, pay your copay. What a wrong turn that was, right? So for the first time, maybe they're saying, wait a minute, there's a price difference? I thought I went in network, I got the deal. Yeah, there's no deal, right? So there's a whole bunch of different prices. So we set the fair price, like I showed you in that graph, and then right below that, you'll notice there's no numbers down there. Even the CFO in a big company, they don't process 20 numbers in their head. Let's make it really easy. It's either good or it's a red stoplight. It also, think about the bias around more expensive is better quality. Some patients, you're through your out-of-pocket max, I'm gonna go the most expensive one, I deserve it. Well, you're not gonna get better care, so we make it a red stop sign, make it really clear. That's not good. Any questions on that? All right. Put it in their hands so they can talk to their doctor in the office about it. Communications and incentives. I won't go into communications because every case is different. You know, it just depends on employers and how you're getting to patients, but it is really important. But you have to really tailor it down to what's appropriate for the environment. Incentives are pretty universal. And what's the biggest incentive in this realm? Cash. So we have a program, you can see it there if you can read the screen from the back. It says, go green to get green. If you go to a green provider, Healthcare BlueBook will mail you a check, in this case, $25. So half of our employers today do that, even if they have high deductible health plans, because they've realized, you know, people don't even understand the benefits half the time. But they understand, if I go here, I'm gonna get a check, and it's great internal marketing dollars, so. Just that's what they get in the mail. It says, you did a great job, you saved yourself out-of-pocket cost, and here's an extra bonus for you for the Go Green to Get Green program. Where we really want to go is, you know, we have this tool facing patients, but how we pull the providers into the equation to make sure we can connect the providers with the patients and make a real marketplace around that. And we work with a bunch of large employers. We also have a free public website just to try to educate the general public. We work with Consumer Reports and Angie's List and the New York Times and the Wall Street Journal and Fox News, et cetera, just trying as hard as we can to get the word out to patients that prices vary a lot. You can save thousands of dollars with a simple phone call. The most frustrating experience I have is when a patient emails us and they're like, you know, I just got billed $5,000 for this colonoscopy and you say it should be $1,200. Why don't you tell anyone about your service? Like, we try. But, you know, it's too late then. It's too late. They have to do it on the front end. So how do we take all these patients out in the community, whether they have insurance or they don't have insurance, and create that marketplace so that they can find those high-value physicians and facilities in their community? We're beginning down the pathway of doing value-certified providers. So really it's sort of doing a good housekeeping seal of approval. You know, this provider that we work with has told us that they care about your quality of care and your cost of care, and they're going to do what's right for you as a patient. So it lets the patient know if you choose one of these providers, if you go to this physician, they'll actually consider where are we going to refer you so that we don't get a $5,000 MRI when you can get a $500 MRI. Where are we going to do your surgery? And so that lets the physicians communicate to the patients that they're aware that there are financial side effects of healthcare treatment decisions, and lets those facilities hopefully get the volume that they deserve. They should have the line out the door, not the hospital in most cases. Next slide. And then reveal 2 or 3 times if you would. One more, there you go. So what does that look like? Number one, just getting their name out there with the price range so patients know, you know, in Indianapolis, colonoscopies can cost, $900 to $6,000 or $7,000, and here's a building that could do it for a good price, in this case, knee MRIs. And then put that certification logo by their name that says that they're committed. If you go in as a patient and say, I'm concerned about cost, I'm on a high deductible, or I want to pay cash, I'll help you. And then finally, book now. Just try to make it as easy as possible so they can actually schedule an appointment with those providers. And we think, to have a market, you need the patients and you need the providers that are willing to be fair and treat them right in a market. But to make all that work, you have to have known pricing and transparency. There has to be some platform there to support that interaction. So that's really, if I divide this up on how we think about working with providers to make all this work and help patients and employers that are paying for their care, and that is, one, we have to promote the providers that have a good value, and so that's what this is designed to do. The next one is there some way, without fighting in Washington or fighting with the insurance companies or trying to re-engineer the whole system, how can we change the economics so that patients and employers care about the high-value provider? So go to the next slide, and then reveal a couple. One more, and one, there you go. So let's connect that high-value provider with the employer, and just as Jay described, let's go to the employers and say, hey, we found a really good provider in your community. They'll treat you right. They just want their bills paid on time. And the payer can continue to pay those claims. Jay has a unique model, but you can imagine if you went to big Blue Cross and said, hey, we want to do this, they're going to say, you're going to do what? And I don't think so. But we got this great ACO we'll talk to you about, or we've got our narrow network around the academic medical center. That's really going to work out for you. So what we're saying is set it up so that we call it value for volume. Talk to the employers. If you'll help your employees come to our facility, we will give you the economics you deserve. And we don't have to change the entire system. We just keep track through the claims data. You had 10 patients went here for this surgery. Here's your extra discount for doing that. And we'll share it with the patient back to that rewards so that they have a skin in the game to get that done. So hopefully employees will receive what they deserve economically for choosing the high-value facilities. Employers will get a much better value proposition both on quality and cost, and the providers will have an actual plan to work more directly with their customer. Ideally, when it's a boom, we may not need to go around the system, but I think today we've got to think of creative ways to make this work for employers and patients on the one side and providers on the other without having to negotiate with Big Blue on how they do their claims. That's not going to be practical. I think that may be the end. Next slide. So we'll open it up to questions. Yeah.
Just to be clear, are the prices that you've been talking about, the prices on your site, are those insurance negotiated rates as opposed to Jay's prices, which are direct pay rates?
Yes, so it can be both. It depends on the context. So if we know that there's a negotiated rate that's different from the PPO rate, then it'll absolutely reflect that. And those providers end up at the top of that list with the promotional language around. In this case, the deductible would be waived. There's a travel benefit for you and your spouse if if they're traveling to here for an inpatient procedure at McBride, for example. But if they don't have that, then it would be the allowed amount in the network. Yeah.
Jeff, since transparency is the buzzword we're all really concerned about, how do you charge?
We do per employee per month fee, and we're transparent about it. It's $1.50. So it's there's some minor variations and stuff, but it's basically that model. So the way we look at it, all the health plans have transparency tools. I did some screenshots. They give them away for free, so that we compete against free. So we have to make it really compelling case when we compete against free. Our math is, if 1%, we know that 100% of employees are not going to shop for care. They don't know, they don't understand, it's too late, et cetera. If 1% per year shop for care for surgery, imaging, cardiac outpatient testing, et cetera, it's a positive ROI. So try to set a low bar to make the whole thing work. That's the plan. Yes?
You're gonna set up a new metric for collecting quality data in a freestanding facility. You know, we know what the numbers are, or the fields that are collected by CMS. How would you go about setting up a new metric system in a free market environment for quality data collection?
Yeah, it's a great question. I'm not going to give you a great answer. I apologize. And I've been talking to organizations that are in the quality, you know, we're not quality experts in our company to try to do that work, but there are other organizations that are, and we try to partner with them, whether it's Consumer Reports or Consumer Union, and I won't name all the others, but we've interviewed a ton of them. We think we've nailed down really good inpatient quality. As I said, I see a gap over there that we really want to close because we think the best value is over on the other side. So I think as close as possible to mirroring those kind of metrics, and try to do it in a very standardized way, and try to talk about it really publicly early on to get support, because what we really need is to settle on a standard. That's one of the challenges in quality data, right? There is no quality standard in this country. Most people use CMS as the base data set, and then they look at it different ways and they bolt other things onto it. And you know, we can live with looking at it different ways a little bit and argue about what's the best way. You start bolting in random stuff, and then it gets really fragmented in a hurry. So I guess my short recap would be try to mirror industry standard quality metrics on the outpatient facility side, try to talk about them publicly and disclose them and get feedback along the way, and try to get as broad a buy-in as early as possible so that we can settle into the most consistent way to do it. And we're all in to help if we can. We'd love to see that develop. Yeah.
So kind of going off of this quality talk, I was just wondering if you have any insight on how patients are making their decisions about what providers to go to. So it seems like you have the cost information, but there's a lot more that goes into that decision, I think, when people are seeking out care. And I was wondering if you have any research on that.
Yeah, there's a lot of good research on how patients make decisions, and it's scary, of course. Most people literally ask their neighbor or colleague. That's the number one way of finding your provider. For most patients. But with the internet, there's a lot of online research. So most patients are going to end up at health grades. They're the biggest. Vitals is probably number 2. Angie's List is somewhere in the mix. And there's a whole host, Yelp, there's a whole host of others. But once again, most patients think about finding their doctor. And they're either going to ask someone, or they're going to go online and look. And if you go online and look, the first 5 entries are going to be health grades. They've done a great job with search engine optimization. So that's how they're finding their physicians, and from there, that's sort of where they stop. And then if they are considering cost, they're either going to go to a health plan tool or a tool like ours and try to do some research around the cost. But once again, if they just look at the doctor costs, they really miss the boat. So what we're working on to develop, we've been against the doctor provider lookup tool because it just does a disservice in reality for the patients, but we can envision a way to make sure that you can find your doctor, and then right next to it they see the picture of what the cost profile would be depending on where they practice and what the procedure is. So, I'm hoping sometime next year we have our own point of view about how we can make that easier for the patients. But today that's just in a PowerPoint that we're trying to figure out exactly how we could do it and give them everything they need in one place and make it simple.
In the absence of your own quality data, would you consider using what's out there, Hospital Compare, Physician Compare, as sort of a crosswalk, until you have your own aggregated data to look at?
Yeah, so we're doing 2 things on quality. One is on the facility side, and we did about a 1.5 year review of all the quality metrics in the industry. And for inpatient quality, we settled on a methodology that looks at all the inpatient data from CMS. And it's risk adjusted, it's volume adjusted, and it's by clinical service category. So we're most excited about that because here the reality is, look at something like Leapfrog. That's good, but you're A, B, C, D, whatever, it's one score. And the fact of the matter is, most hospitals do a lot of services, and they may even be good at some of them, but they're not good at all of them in most cases. So we think you're doing a disservice to the patient to call a hospital an A overall when they may be an F on orthopedics. So we're looking at cardiac surgery, cardiac medical, diabetes care, orthopedics, neurosurgery, et cetera. So there's about 36 domains, and you can look at the specific rating for a hospital, and you can rank those hospitals both regionally and nationally. There are some communities, Toledo maybe, where you might not have a great choice locally. You may need to drive to Columbus. There are other places, Dallas or Houston, where we may have several hospitals that are the top nationally. So we're going to be putting that in for the patients to use on the inpatient side, because that's one of the missing pieces. Then the costs are going to be even harder on the inpatient because they're all over the map, even patient to patient in the same facility. Then on the physician side, we're looking at we haven't settled on that yet, but what we're really looking at is efficiency and any kind of outcomes data. And we like some of the stuff that the Prometheus system has, so we may end up using that, but we haven't finalized that yet. Do you have any good ideas on that one?
Not quite, but I know I'm the executive director of an IPA in Connecticut, and we sit on some of our own data that we've done for disease management over the course of many years. So, you could look at as you get your physicians, that are you pair up with.
Right.
Use their own data.
Yeah, and we do encourage that. I'll tell you, when I started, preaching transparency to hospitals, and I go meet with them and sit down in their executive room with the CEO, CFO, CMO, and the chief medical officer always said, "Yeah, but you have the price. What about the quality?" And I said, "Great, give me your quality data and I'll load it up." And they look like they don't have quality data. So, it's a real challenge for them. They want to talk about quality, but most organizations haven't really done the heavy lifting to have good quality metrics. Good question.
You put the slide up earlier about trends in healthcare spending, and 65% of healthcare spending is a result of care for complex chronic illness, an illness that occurs over a lengthier period of time. And is your program addressing for patients the price and cost of care for those illnesses that they'll be encountering care delivery over longer periods of time?
Yes, so great question. And the challenge we have with chronic conditions is each patient has different specific things that they get. Oncology being a great example. How many drugs are you going to get for your chemotherapy, and how many courses and overhead. So what we've done to make it manageable at this point is to talk about the specific components of the care along the way. And so we have like condition pages, and you can look up, maternity or diabetes or heart disease, and then it will list all the things you might have, and you can price out the pieces. But we don't have episode summaries right now. We don't have a good way to evaluate if you go to this facility over the course of the year, are you going to get a better quality or economic outcome? We haven't not tackled that yet, but as soon as the provider side can document their quality and offer some bundles around that so it's comprehensible, then I think that's a really good opportunity. Other questions? Yeah, Jay.
Providers that are seeking to expand their bundles into more of these chronic care episodes.
Yeah.
So again, it's not being driven by you or me necessarily, but the provider community seems to want to address that.
Yeah, and then the challenges of the patients, right? Because if you pay a bundle, you want the patient to stay where they're supposed to be. And patients always have their own ideas over time. So I think if we can get there, and the more standardized the care pathways and the more locked in patients are to systems, the easier that's going to be. Yeah.
This quality measurement is so difficult. Like one of our hospitals in Tucson advertises, we're one of the 100 top hospitals in the U.S. Well, frankly, I don't believe it,
Right.
but I don't know how they came up with that. It so much depends on, did the doctor make the right diagnosis, and how do you know whether that's true? Secondly, is the hospital telling the truth?
Mm-hmm.
Then are they measuring things that really matter, or just compliance with their practice guidelines? I don't know how you do this. If you come up with something good, that'd be great.
The billboards are tough, so I gave a talk to about 100 hospitals earlier this year, and the speaker before me made a good point, which addresses what you said, and that is there are over 700 top 100 hospitals in the U.S. So everyone's got their U.S. and News and World Best Report. And so I trained at Duke, and they send me an email, and it says, we're number 4, U.S. News and World Report. And I thought, how embarrassing. But, I think it's a good facility, but, really, U.S. and News and World Report, that's what we're going to rely on. So great question. And once again, our approach is no hospitals, number 1, or even top 10 or 25% in 36 different clinical categories. So if I'm going in for knee surgery, I'd like to know they're good at knees, and if I'm going in for heart surgery, I want to know they're good at hearts. So we got to be careful, but as you think about the patients, right, if it's a low-end service that has, outpatient MRIs, outpatient cholesterol tests, those are commodities, if you will, and people will consider price. When you get to the other end of the spectrum, I need a heart surgery, it's about brand. And people know that. So they advertise we're top X, and they're building their brand, and it may not be tied to reality at all. It's a branding game. So it's a tough thing for all of us to do. You got to solve that brand challenge in a very rigorous academic, educational way for the patients. Yeah.
And related to the challenge of measuring quality, and granted, this is not necessarily high cost per episode, but high volume in terms of primary care. A lot of the primary care physicians that this would appeal to are opting out of taking insurance, third party, Medicare, and so forth, because they want to keep their practices very lean and offer cash prices. So the measurement of quality is actually quite expensive. You need to have a lot of expensive systems to do that. So I think it's a challenge, and if you have any ideas on how small primary care offices, especially direct primary care offices, can measure quality so that employers would be attracted to them, I'd love to hear your thoughts on that.
Yeah, the challenge physicians have, a physician, is that if you want a statistically valid measure, you may need more patients than a typical physician has in a panel. So most metrics are at the practice level, groups of doctors. Which is, it's more valid, but it's also less relevant to a patient that's going to one doctor in that practice. So I don't have the magic answer for that. The best you can do is document your compliance with standards of care, which is different than outcomes, and participate in rolled up quality initiatives, where you think you fit into that pie. A lot of if you're an independent doc with cash pay only patients, hopefully you have a EMR or something in place that's tracking compliance with standards of care that you could report out, because in that environment you won't have any health plan metrics to rely on or any other metrics.
Have you ever looked at, I think it's John Wasson from, I think it's Dartmouth, How's Your Health? Do you think that is a valid measurement?
I'm not familiar with that one.
It might be something to look at because it's very inexpensive, and it might be something that would apply across the board.
Yeah, that's a great idea. We will investigate. Anybody else familiar with that one? No. One person that was there. Yeah. Great. Any other questions?
I now have one, but
All right.
you talked about a business model where you assume if there's a 1% take-up rate of what you're doing, then the employer is more than made it. If you see a 1% take-up rate, do you see that then accelerate as you have continued on, or have you been doing this long enough to be able to track a market movement?
That's a great question. I have a slide for that one. So this is the kind of outcomes, and they're all over the map, depends on the benefit design, the communications, incentives, but this is an example of a group where you can see on the bottom half is 2011, and you can see the distribution. These were MRIs without contrast, and you can see red, yellow, green distribution, and then you can see in the outcomes year the shift in patient volume to the higher value providers. And that's an on-site clinic thing. I won't spend no time on it, but to answer your question, this is what that looks like over time in a good scenario. And that is, base year, maybe 27% going to the high value providers. Year one, about half. Year two, almost 2/3. We don't see this in every case, but that is reproducible depending on the context, the incentives, the benefit design. What we know, most patients, once again, 80% of the patients but 80% of people are not patients, right? They're healthy, they're at work, they don't use the healthcare system, maybe not the whole year. What we do know is once you shop for care once, and I'm sure Jay and Keith can speak to this, those people come back because they realize this isn't so hard, it's worth my time, and it's good for me. So it definitely compounds on itself over time. Great.
I might just, because I do have a little bit of experience on that. For us, the key, like you said, is plan design, some of the incentives out there. But the other key, especially for us when we work in a self-insured environment, is you've got to be able to train those employees where they understand that, that 20% that's coming out of their pocket or that copay that's coming out of their pocket, that's not the entire cost picture. The insurance is them. I mean, once they understand that there is no deep pocket out there, that every dollar spent is going to be accountable back to them in some form or fashion eventually.
Right.
Now there's buy-in. But before you have that, when they have an insurance mentality, you're right. It is very, very difficult for them to start to buy in. But Americans like to get a good deal. Americans don't like to get took when it comes to making a purchasing decision, even in healthcare. But they've got to start seeing it as their money.
Yeah, we say people have a fairness gene. They don't want to get taken advantage of.
Yeah, Keith.
Hi, Jeff. Thanks for coming.
Thank you.
Great presentation, but I want to make something very clear, and I don't want to misstate. One of your slides showed that, or your conclusion was, now we've got to get the providers on board. And for the providers that are in this room, you need to digest that. That's what you said. The demand for providing transparent, high quality, high value service far outstrips its supply. And I believe that's just a way of restating what you said. We've got to get the providers now. So there's so many people, and maybe even some in this room, who are scratching their heads and nervous and anxious about making the move to practicing in this way. But that slide was powerful because, that's your conclusion.
Yeah, thank you. Yeah. We need, to get a marketplace, you got to have both sides of the market. Yes?
How about the employers that are using a real network?
Mm-hmm.
And in that network, there's language that says you can't use a provider outside of Blue Cross's network. How are people getting around that as far as facilities and the physicians are concerned?
Every contract is different, and every network has, even within their own providers, they have variations, and certain hospitals that have sweetheart deals with protective language. Another one is you can't do transparency, include us in it, or you can't do it at all. So, fortunately, over time, that stuff's whittling down, at least on the transparency piece. I don't know the specific answer. You just have to basically go through the agreement and see if you can comply with it or see if you can renegotiate it. And we've seen that happen working with our payer partners. Sometimes you get stuck in a tough place. It really depends on the facts of what does the agreement say you can and can't do. Most benefit plans have out-of-network benefits, so you usually have an escape valve on an out-of-network basis. Now, most benefits are really punitive to the patient on out-of-network, but can you waive deductible and copay if they go out-of-network? Usually that would not run afoul of most standard contract provisions.
I think it's an easy answer, and we see employers struggle with it all the time. If you're paying someone to provide a service for you and their practices cost you more money, you fire them. I think employers have to be in positions where they're prepared to fire vendors that aren't providing them value, and they have to be in a position where they're comfortable going to health plans or PPOs and saying, these are the abusive facilities, these are the abusive docs, remove them from the panel. Because in so many of those arrangements, you're not the customer. You're the paying party, but the customer is often on the other side, and so, but it's tough, and we see it, and there's rental networks that'll take you. But it's tough, and people have to be able to stand up to those people and just fire them.
We have time for 2 more questions.
Thank you very much for your presentation. I this is not a question, if I may respond, if I'm allowed to. And because this is very important, what we're discussing here. And the employers are wishing this would be the mainstream. When we make this mainstream, it will happen. Right now, the employers have their obligation to their employees. And if you have 20 employees or 50 employees, it's different from 5,000 employees. And no employer that I've talked to wants to be in the insurance business. That's not the business model. So talking to some of the insurance and risk, alternative risk in insurance, they said it's sometimes very difficult to segment your insurance policy. And the big players in the field will not allow you to do that until we mainstream this effort.
Yeah, and I'm not advocating to go without a network. I'm saying you call someone like First Health, that'll put it in writing and say you can do whatever you want, and you still get a national network. So I'm not saying an employer would go naked and just hope there were enough Keith Smiths to fill every need in the world. That's not realistic. You rent a PPO network that says we are what we are. You're renting our contracts. You're not asking our permission.
One more for Dr. Rice. Right here,
Great presentation. I'm a doctor here locally, and one of the things that I did this morning, seeing patients, is wrote a prescription of an MRI, and I gave it to a patient, and I said, you got to go shop this. A high deductible plan, and I'm part of a large health system, one of the largest here. I could have referred into the health system and had maybe thousands of dollars more of costs generated. Another thing is our office got calls today on prescriptions I wrote yesterday from pharmacies, and the patient just said it's too much. And so I changed it to an alternative. And so my question is, have you considered using your model and putting it at the fingertips of doctors? And we live on the electronic record, and we live with pharmacy plans and formularies, and we're always using our tools to further understand tier 1, 2, 3. And as those become adopted, the same type of, but it needs to be integrated in the EHR, or it's never going to be actionable, and the patients aren't going to receive it, knowing the volume of care that we're generating in the primary care side of things, as opposed to online data searching.
Yeah, that's, first of all, great for you. Not just good, great for you to care. We do envision that, and part of that value certified providers that the provider will load this into their technology, and it can be on their phone, into their EMR or patient order entry, et cetera, so they can actually use it and make those. The great news for physicians is you only have to look up the MRI centers once or twice. You don't have to go on every day. Once you know where to send them, you know where to send them until it changes. That graph right there is what is an example of putting this technology in the hands of the doctors in a primary care medical home clinic, and you can see the green is the ones using the tool, and the control group had access to the patients had access to national carrier tool, but you can see there's 20 to 120% improvement in performance across, I got cut off at the bottom, CT imaging, colonoscopy, and cardiac diagnostics. So what we know is it's hard work to get patients to think this way and do it. If we can get doctors like you to say, I care, and I'm going to refer them to the right place, it's all downhill, right? They don't question you. If you send them to a $500 MRI center that you trust and you'd like to work with, done. There's no question. So that's awesome.
That's why I think an app for that would be really good for the physician, because there are some physicians who haven't joined the large ACOs because they don't believe in the quality or the pricing within that ACO.
Yeah.
So they're on that outside.
Yeah, we have that out, so that's good. Great, thank you guys, I appreciate it.